Thanks, everybody, for having me here. I really appreciate it. I'm Jesse Goodman. I'm a clinician in infectious disease and public health person who's functioned at both the local and the global health level. And I like what Lou just said about that, acting locally and globally, or whatever the slogan was, because we're sort of doing both. And if there was ever, the major problem, we're focused on access and appropriate use of medical products throughout the world. And a major focus has been on antimicrobial resistance, which I started working in maybe when I first met John and entered the government, at first under Clinton and then Bush, and we made the first national plan on antimicrobial resistance. But, as everybody has heard in the media, sometimes in sensational terms, we do face the prospect of a world without effective antibiotics. And I see this whether across the street at our hospital here or, communing with colleagues from around the world. Particularly at a global health level, the challenges include resource constraints and competition for resources in these at-risk areas, and the fact that what I've termed a phrase for antimicrobial resistance is a slow emergency where until it happens that we have widespread untreatable organisms, this seems quite abstract because for most clinicians and public health personnel, there still are antibiotics that work. But our lag time in developing new antibiotics is typically 10 to 20 years if we're lucky enough to have the incentives lined up and the science lined up and develop them, which is a whole other problem. So it's been really hard to get this on the map of the global community. Every country has plans, but they don't really have resources to implement them. And there's really absent surveillance of the problem. So what we've tried to do in this period of diminishing resources is to find ways to leverage existing data and resources and make a difference. One is to really go out and say, can we find data on some of the worst antimicrobial resistance threats in places where there have been gaps in data. So for example, in Africa, WHO reported only data from about either 7 or so out of 40-something countries, and we were able to find data out of the majority of countries in Africa and put it all together and publish it. And recently did something similar on Southeast Asia, which is shown here, and in that process illustrated to people that the two what I would describe as antibiotics of last resort, carbapenems and colistins or polymyxins, that we use to treat infections like E. coli and Klebsiella when they're resistant to other organisms, that genes that confer resistance to them are circulating in common in about 7 countries or so, which are shown on that map. In addition, we've engaged with practice and policymakers on the ground in a variety of ways. I mentioned a couple of examples. A group out of Hong Kong University is trying to look at how you should implement national programs in antimicrobial resistance, for example, in China. And we're working with them as the sort of US representative to that. John here knows because he helped engage me in it, and some of the others here. We did a program trying to engage the faith-based community, and one of our new colleagues, Deus Bezerra, we were happy to include him in the most recent effort. And then to the local level, one of the first things that I did when I came to Georgetown, now about 4 years ago, was join with infectious disease nurses, physicians, pharmacist colleagues across the region in most of acute care to share data on resistance and share best practices. And that's a very active coalition we have called ROAR. And to Dr. Lafredo's comment and many others, there are great similarities between sections of what the challenges we deal with here and in less resourced countries. So one project we've done with the DC Health Department is looking at long-term care facilities in the District of Columbia, which are under tremendous financial pressure and yet also have to achieve high-quality health care in an underfinanced environment. So we've worked with them to try to improve care and in infection prevention and in use of antibiotics in long-term care facilities. And then Paul Ropey mentioned that he and I are involved with fellows supported by the U.S. Pharmacopoeia, which advances medicines quality across the world. One of the challenges is we have substandard medicines around the world, and their use helps worsen the resistance problem. And we're involved in a study of how the WHO antimicrobial resistance action plans are being implemented in countries with respect to protecting medicines qualities. So those are just some examples, and I'm thrilled to be here and to work with any of you in any way we can. Thanks very much.